gives an overview of muscle tone, both normal and abnormal. This slide details a cartoon of the structure of muscle. In the top panel labeled A, you see a picture of a muscle fiber, an example of a muscle fiber. The muscle fiber itself is made up of individual units called myofibrils. The myofibril is composed of individual units called sarcomere. By definition, a sarcomere goes from one Z-line to another Z-line. The sarcomere is composed of really three basic elements: the myofilaments actin, shown in blue, myosin, shown in green, and titin, shown in yellow. So normal resting muscle tone is comprised of the intrinsic and passive stiffness of the muscle. If a muscle is at rest, there are going to be weak bonds between actin and myosin. If a person has a muscle that is immobilized, such as being in a cast for a long period of time, after as little as 2 weeks, you can try and stretch out that muscle and you'll feel an increased resistance because the muscle itself has been immobile. If the muscle is contracted, then you have maximum overlap between the actin and myosin, and if you immediately try and stretch out the muscle, you'll feel an increased resistance to that muscle stretch. However, if you provide a slow, gentle stretch, this will result in gentle detachment of the actin and myosin filaments, and a faster stretch will result in increased stiffness being felt because the actin and myosin are still partially attached. Titin provides elastic properties, as I mentioned before, and it's going to provide mobility and resistance to muscle stretch. The spinal region is also important for normal resting muscle tone. In the spinal region, you're going to have the integration of somatosensory afferent signals as well as the descending motor commands. Both of these regions have an impact on active movement as well as reflexes. Hopefully this is still a review for you. This slide shows a cartoon of the phasic stretch reflex. And here you see that with a simple tendon tap, you get activity of the muscle. The tendon tap works to stretch the muscle, and a stretched muscle becomes active. This slide shows another kind of reflex, which is known as reciprocal inhibition. In this particular instance, an agonist contraction is going to result in the antagonist relaxing. And another reflex, autogenic inhibition, happens when there's very high muscle tension. This will promote muscle relaxation. The stimulation of the alpha motor neuron signals the type 1B efferent to signal the Golgi tendon organ to relax. The last reflex, which I'm not sure you've been exposed to before, is known as the H reflex, and it's also known as the Hoffman's reflex. This slide shows a cartoon where in the top panel you see a stimulus. In the case of an H reflex, this is always an electrical stimulus, so E-stim is applied to a muscle, and this stimulation of muscle results in two recordable waves or reflexes shown in the bottom part of the panel. You can see the first wave is known as the M wave, and this is actually due to the muscular contraction in response to the application of the stimulus. The second peak that you see there is called the H reflex. The H reflex happens because the stimulus is applied. Not only does the stimulus, this stimulus goes back to the spinal cord region, and if the alpha motor neurons are in a pre-activated state, then there's a latent response that will also cause another muscular contraction. This latent response that travels through to the spinal cord region is called the H reflex, and having a large H reflex is indicative of having increased activity in that alpha motor neuron pool. This is one way that physicians use to measure spasticity in a muscle. So reflexes are all require a form of proprioceptive input. So why should we test reflexes? Well, testing reflexes will give us information about the peripheral and spinal circuits, things you've learned about before, such as muscle spindles and GTO reflexes, Golgi tendon reflexes. And they also provide information about the level of background excitation in the spinal cord, such as the new H reflex I just introduced you to. Again, the H reflex, it's similar to the tendon tap or the phasic stretch reflex. In this case, they use E-stim to substitute for the tendon tap, and this E-stim produces both an M-wave muscle contraction directly and an H reflex, which comes from the pre-existing alpha motor neuron excitability. So as a summary slide, you see here factors that are affecting resting muscle tone. You have descending motor commands. You have proprioceptive information that you can determine through reflex activity. You can have weak bridge binding of the actin and myosin myofilaments, as well as titin. All of these interact together to produce muscle's resistance to stretch.
Normal muscle has normal muscle tone, and this is determined by moving the arm quickly or slowly through a passive range of motion, arm or body part. What you should feel is a minimal resistance to passive stretch.
As far as abnormal muscle tone is concerned, there's two kinds. The first kind is known as hypotonia. It's also known as flaccidity, and it is characterized by an abnormally low resistance to passive stretch. So when you take the joint through the passive range of motion, you can move that muscle through those muscles through very, very easily. There's absolutely no resistance. Ordinarily, you'd feel just a little bit. Hypotonia occurs in cerebellar disorders and lower motor neuron lesions, as well as spinal shock following an acute upper motor neuron lesion. The other kind of abnormal muscle tone is known as hypertonia, and hypertonia is characterized by an abnormally strong resistance to passive stretch. This occurs with upper motor neuron lesions, as well as some basal ganglia disorders. As far as hypertonia is concerned, there's two basic types. There's spasticity, which is a velocity-dependent hypertonia, which essentially means that the faster you move the joint through the passive range of motion, the more tension you're going to feel in the muscle. And the other kind of hypertonia is known as rigidity, and this is velocity independent. As far as rigidity is concerned, there are a number of different kinds. Two that we'll talk about in reference to brain injury patients are decerebrate and decorticate rigidity.
Oftentimes, after a patient has had a stroke or a brain injury, the spasticity leads to something called posturing. And the posturing that's shown here in this slide in the upper extremity is the most common pattern that you'll see, and it's an upper extremity flexion synergy pattern. With this pattern, the scapula is going to be retracted and elevated, the shoulders adducted, internally rotated, and depressed. Elbow is going to be flexed, forearm supinated, and wrist and fingers are going to be flexed. This pattern can also be seen in a patient with milder spasticity such that when they try to use the extremity that's been affected, all of the muscles move in this pattern. And as I mentioned, this is the most common pattern that you will see in the upper extremity, but you should also be aware that there is the possible presence of an extension synergy pattern for the upper extremity. And the extension synergy pattern is listed in table 614 on page 169 of the Feld textbook. In contrast to the upper extremity, the lower extremity also has a synergy pattern. In this case, it's an extension synergy pattern. And that's shown in the picture on the right. It is the most common pattern that you will see in the lower extremity due to spasticity. Typically, patients will present with their hip extended, adducted, and internally rotated. Knee will be extended, and the ankle is plantar flexed and inverted. Again, even if the person isn't stuck in this particular posture and they have mild spasticity, when they try and take a step, the spasticity will kick in. It's very common for spasticity to kick in when patients are challenged. So instead of going through swing phase with any knee flexion or hip flexion or ankle dorsiflexion, their synergy pattern is going to kick in and they're going to be stuck in extension, making it very difficult to clear the foot during swing phase. Now, in addition to spasticity, there's also another kind of hypertonicity known as rigidity. The difference between rigidity and spasticity is that rigidity is velocity independent. And it's velocity independent no matter how fast or slow you're moving that joint through passive range of motion, you're going to feel an increased resistance to passive stretch. Overall, there's two types of rigidity you need to be aware of. The first is known as cogwheel rigidity, and that's what is kind of depicted on the picture of the right-hand side of the slide. Cogwheel rigidity is often present in patients with Parkinson's disease. It's also present fairly early on in the disease process. And what happens if you take their arm or their elbow or their knee and you move it through passive range of motion, you can feel a pull, 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 and resistance kind of intermittent, like it would be catching the wheels of a cog when you go through that passive range of motion. This is different than lead pipe rigidity, where lead pipe rigidity is you're going to have just increased tone throughout the range, and the person can be as stiff as a lead pipe. The last term that you need to be aware of is known as an associated reaction. Associated reaction is an involuntary movement during a stressful task. And here in the picture on the right, you see a little boy who's trying to use scissors, which is very difficult, and he's concentrating so hard that he's sticking his tongue out. A lot of times you see it with that associated reaction with little children. When they're really concentrating hard, they stick their tongue out, and that's just an associated reaction. Well, with kids, it's easy. If you tell them to put their tongue back in, they're capable of doing it. What happens in a patient post-stroke or brain injury is that as they're walking, their arm is going to go into flexion. Okay, it can be a full flexion synergy pattern, or it just could be elbow flexion. And as any stressful task is going to cause this elbow flexion to be seen. So the elbow flexion is the associated reaction that happens in a patient post-stroke. However, if you tell that person to straighten their elbow, they're not able to do it. So it's an associated reaction that you will see when patients are doing a stressful task. Another body part that's not involved in the task will have an involuntary movement.
And hypertonia. Well, with hyperstiffness, it's an excessive resistance to muscle stretch at the level of the muscle. It's a result of a loss of sarcomeres and increased weak binding of actin and myosin at rest, as well as muscle fiber atrophy. When the fibers shrink, it's going to be harder to move that muscle. This hyperstiffness an example could be something like contracture. After wearing a cast for a long period of time, the muscles are going to shorten, and when you try and stretch it out, you're going to feel stiffness. And how do we treat hypertonia or hyperstiffness? In a complete spinal cord injury, there's a loss of all descending neuronal control, and after spinal shock, the phasic stretch reflex is hyperactive. The polysynaptic spinal reflex is reduced or absent, and there's a loss of influence of upper motor neuron on the spinal circuits. Focus on reducing muscle stiffness in this case, and this is done by baclofen, which will inhibit the stretch reflex pathways and the hyperreflexia, but it does not, baclofen won't touch the hyperstiffness at the level of the muscle. In this case, we would definitely work on stretching the muscle to decrease the level of stiffness. However, in the case of a patient that has undergone a stroke, there's rarely hyperreflexia. There might be decreased upper motor neuron activity resulting in hypertonia or spasticity, but some control is usually maintained, and there's variable levels of hypertonia in this patient population. If you have a patient with hypertonia, one suggested treatment is weight-bearing activities to help decrease the tone. However, if the patient also presents with hyperstiffness due to immobilization of a limb, we must also address that hyperstiffness at the level of the muscle.